thank you for your attention. Sharna, yeah.
Thank you, Katie, for the lovely presentation. Just something, I'm sitting here and reflecting that, we're talking a lot about pharma and doctors and the prescription. It made me think about India. Mm-hmm. And the farmers in India are, they have no regulation.
Not
so I have family full of doctors. They get trips to the US fully paid for. They have conferences fully paid for. But they don't have an opioid epidemic.
Yeah.
So it makes me think that it's definitely that iceberg lower down more than just the opioid tip. So this was just my comment, and I don't really have a question, but
it is it's a complex issue. You're absolutely right, and the way we view pain also affects how we treat it. So if we view it as a purely physiologic messaging system, then it makes sense to inject these molecules that bind with receptors that block the message from even going anywhere. It makes sense, right? But that's a flawed model. That's a flawed framework, and it leads to worsening outcomes. And then there's access issue, and then there's suffering issue, and then there's so many layers to this. But it's true, different countries have different problems, different access, and I think it's hard to debate that the ready access of opioids in the United States was a good thing. And in fact, when there was that push to prescribe and keep prescribing, and it's safe and you're not going to be legally prosecuted, doctors, you're going to be fine. That was a practice injected into a system that wasn't ready for it, that didn't have any screening. If you go to the doctor and get a rotator cuff surgery, for example, you have a surgery for something that is fairly routine in our country now. It might be a bad example because the data doesn't really support that so much anymore. But you know what I mean, right? You go to get an orthopedic surgery, and it's standard practice even still to get sent home with 30 pills or a month's supply, whatever the dosage was prescribed. And people don't get asked questions about risk. They don't get asked questions about family history of risk. They don't get asked any questions about access. Do you have kids at home? Where are you going to store this? Are you going to lock it up? It's just not treated as a dangerous substance. I don't mean to be on a soapbox about opioids, but I'm talking about a cultural perspective issue where we're trying to use it's like a square peg in a round hole. Like we keep trying to find these fixes for a problem that's way over there, and we're focused here. And I'm glad that some enlightenment is coming to some wider circles. Another question? Jody.
Thank you, Katie. That's great. I've been a massage therapist for 30 years, and I've worked in multidisciplinary clinics. My wife is a chronic pain patient that is very responsible but has had many surgeries. We have physiatrists coming into our little rural area, but their end run around this is epidurals. And because I understand the whole thing, it's a high-ticket item. So how does one talk to someone that's just like, I'm not doing the pain stuff, but I'm making big money shooting up people?
Yeah. I'm going to punt part of that.
Sure.
Just because it's outside my scope of practice to talk about the clinical decision around injections or not. But I do very much respect, and I'm looking at Dr. Katie because you've collaborated a lot with, and Sharna too, a lot with Kevin, I can't say his name, Coccaro. I will get that right one of these years. Kevin Coccaro is an anesthesiologist, pain-boarded pain specialist who did all the injections and all of that. And I work with anesthesiologists who where I work, people don't get paid more or less for more procedures, right? It's a federal system, so they get their salary no matter what. And yet, I feel we have a lot of work to do to educate patients and their expectations around what this thing is going to do for my pain. That's on us, right? The people who aren't injecting as well as the people who are injecting. Because I can talk till I'm blue in the face, and I've sat there. Here's one example that was striking to me. I had a student with me. I work in an interdisciplinary clinic. As I said, we have set up an assessment model in one of our clinics where in one afternoon we see 2 patients in 4 hours. It's a lot of resources. for 2 patients, which is amazing that we can do this. So the patients go from one provider to the other for an hour assessment with each provider. Then we sit together as providers and talk about the plan, and then bring the patient back and say, what do you think? What would you like? What do you want to have happen? It's wonderful. But you don't understand, I don't think, until you're in that situation, how differently people will act and behave or present their case to different types of clinicians. And this was so poignant for me. I had a student PT who was following the patient around to each visit just to see how all clinicians did things differently. And this was a 32-year-old woman who went there with widespread pain. She had been diagnosed with fibromyalgia, but she sat in the doctor's clinic first, came to my office last, had gone to the psychologist assessment in the middle. And before the patient came to talk to all of us, my student shared an observation. She said, this young woman sat in the doctor's office, the doctor went through her assessment, and the doctor asked all the questions and then asked whether the patient had any questions. And the patient said, yeah, have you read my MRI? I got an MRI because my back's been really hurting. And the doctor, who is well-versed in all this stuff, who is a great clinician and really broad thinker, I know she doesn't use nocivic language. I know she does not do that stuff with the patients because I work closely with her. But she said something like, yeah, it just shows a normal amount of arthritis for your age. It's not a big deal at all. Yeah, and the patient said, okay, thank you, doctor. And then went to the psychologist's office and fell apart in a puddle of tears, scared to death about the arthritis that's crumbling in her spine. And none of that was displayed to the physician. The physician came to the team meeting, oh, this is a simple case. And we all went, no, she's a mess now. And we were able to recover that. And then we had the opportunity to have that conversation with the patient. But this stuff happens all the time, and we don't know it. So what I think you can do in your discipline with your minute interactions with these individual patients is perhaps explore what their fears are, what their worries are, what they hope to get out of a pain treatment, and then see where that belief comes from. I mean, we don't have to be psychologists to do that. What is driving that belief? Because maybe there's another way to get there. Yeah. Question over here.
Yes. In the system that I've been working in, we are, as physical therapists, we're asked to rate pain at the beginning and the end of each 45-minute session. So, I, of course, thought that was pretty absurd and began to try to change that policy within the hospital system. Got to the point where I was able to get confirmation from Joint Commission. That is not required because that was their explanation that the hospital gave.
I know, circular reasoning, right?
Took that to the hospital directors of rehab, which then passed it, and they were shocked that there was not Joint Commission. They took that up to the quality control person who said Joint Commission doesn't understand their own rules.
Adults don't like their beliefs to be challenged.
So, any advice? So what I'm looking for quite specifically is there research out there to show dangers of asking that question? I mean, to me, it shows the therapist feel some pressure to do something to get it to change. The patients feel like they're failures if it doesn't change. But I don't have any documentation to support that belief. Yep,
get in touch with me because I put together a case too for my administrators. I made the mistake of launching into an excited little diatribe on this pilot project we're going to get started on after the meeting last year, and I came back to my pain committee and went like, yeah, let's rah. And then I went to a medical executive committee, and I unfortunately did not prepare my talk very well because major executive leader in response to my effort to say we'd love to just try and use a different form of assessment and in one clinical setting, just one little thing, she said, but it's required. And I said, interesting you say that because the Joint Commission never required that we ask 0 to 10. And she stopped listening to me. And it was a big mess, and it still is a big mess. So I might have to repair that relationship before I can get anywhere further. How you talk about it is important. But because I had to prepare for further arguments, I have collected some things. And there are some papers that do show some of the possible negative impacts. I don't have those here, but what I did include but then took out again because I always have too many slides, is that the VA published this 6 years later. The answer is We retrospectively reviewed medical records at a single medical center to compare providers' pain management before and after implementing the initiative and performed a subgroup analysis of patients reporting substantial pain, i.e. 4 or more. And the participants were mostly primary care providers in a general medicine outpatient clinic. And I'm going to not bore you with the details, but the quality of pain care was unchanged between visits before and after the pain initiative. And lots of different metrics were used to describe that, and the p-values and the numbers of people included in those. And routinely measuring pain by the fifth vital sign did not increase the quality of pain management. Patients with substantial pain documented by the fifth vital sign often had inadequate pain management. Now, there's a lot to this. This, I think, could serve as a general idea that, hey, healthcare as a system may not improve. And the executives care about numbers and data and performance measurements, right? It doesn't improve performance of the doctors, and there are some other studies that I know about that could highlight the potential detriments of asking this number all the time, or the way that we might act. I mean, this is in psychology journals mostly, and how asking relives this question of how much do I hurt, refocuses the brain on things and helps the rumination component, which we know in catastrophizing measures, the pain catastrophizing scale is very predictive of functional outcomes. And I would say what you can do as a physical therapist, any other physical therapist, my buddy Renee, she was with me in that picture in the first slide. We struggle with healthcare insurance providers and reimbursements. We have to show functional improvement, okay? And a lot of people use the pain scale. I've never understood that because it's not functional, it's subjective, right? But you could say, I'm showing functional improvement and I'm tying it to pain by saying the patient goal will be to get dressed 5 days a week without pain interference. It's measurable. Or with 0% or 20% pain interference. Whatever, you can put a number on it. You can actually change how you're writing your functional goals and satisfy the insurance metric requirements, which is really what they want to know. How are you measuring improvement? That's it. And I would argue the 0 to 10 is not good, because if we have big record-keeping systems in the VA, and a nurse I worked with looked at that, and across the board, numbers don't change when people come through the clinic for chronic pain problems. They just don't when you collate all that data. The number stays the same, and you probably have these patients who say, I don't know, it's always an 8 out of 10. I don't know, it's always there. It's constant pain, right? The number doesn't help us do a better job of treating people, in my view.
All right, we have one more question online.
In your opinion, to change culture, what do you feel is of greatest value? Working from within established systems, working from outside that system, or some combination or collaboration between both strategies?
Yes, combination and collaboration, which is, again, why I'm excited to be here, because this is an outside the norm kind of venue. And as this gentleman said, I'm sorry, your name was? Jim. I know we've met before. As Jim said, he tried to buck there. He tried to push back, and he was told no. He was told no. The people who wrote the standards don't even know what they wrote, right? That's very immature thinking, and I think. So just putting all your eggs in that basket is not going to cut it. So I'm working with administrators. I'm working with the people on the ground, the frontline clinicians who are excited to make some change. I'm educating patients about it. I'm coming here. These are the ways that we can start to influence and have a ripple effect. And I don't think it ever works to just be in one place, but I also know that you can't have unlimited energy as a clinician. I mean, Keith did a great job of summarizing in a tiny little synopsis of what it takes to just get through a day. We're people too, right, clinicians, and we have huge lives to manage, and there's only so much bandwidth. So, put your energy where you can, but be informed. I think that's the biggest thing, is if you're ill-informed, you're not going to act. You're going to feel like there's no change possible, that this is just how it is because bigwigs say that's how it is. So question that first, get informed, and then figure out what steps you could take to make a small change where you are in your inner circle, and then disseminate from there. It's a good question.
All right, thank you so much.
Thank you.